Blood Horse Plus, available through bloodhorse.com, provides exclusive, timely, and unmatched content to subscribers, including Fox Sports, Blood Horse branded weekly programs, a detailed stakes winners section, behind-the-scenes videos from Blood Horse staff, on-demand access to deeper horse statistics, and a $5 monthly credit to equineline.com. Upgrade to Blood Horse Plus today.
Are you paying too much in taxes? The Green Group can help. There's a reason the most successful owners, breeders, and horsemen select the Green Group as their tax advisors. They save you money and share successful strategies. Over the past 40 years, the Green Group founder, Len Green, has owned and bred some of the best racehorses in the history of the sport, like Eclipse Award-winning champions Jaywalk and Wonderwheel. His DJ stable competes at the highest level and has received the game's most prestigious honors. Len Green's in-depth, hands-on industry knowledge, combined with cutting-edge tax-saving strategies, has produced positive results for his clientele and has made the Green Group the top-rated accounting and tax firm in the thoroughbred business. For a confidential and complimentary consultation, contact us at 732-634-5100 or visit our website at www.greenco.com. The Green Group, proven strategies to save you taxes.
Established in 1982, Rood and Riddle Equine Hospital is a worldwide leader in equine healthcare, providing a full menu of specialties of services and treatment for all breeds and disciplines of horses, from the family companion to the high-performance athlete. Learn more today about Rood and Riddle Equine Hospital. Visit roodandriddle.com or call 888-773-4838.
Well, welcome everybody. My name's Gary Falter with the Jockey Club, and I'd like to welcome everybody to today's online panel. And this is the 9th panel in our series of online Zoom panels this year. We still have two more, one more in November and one in December. And today's panel includes a recorded surgery session at Rood and Riddle Equine Veterinary Hospital, along with the surgeon that performed the surgery, Dr. Larry Bramlage, explaining the surgical process. And before we get started, I'd like to recognize our sponsors, starting with the presenting sponsors, Bessemer Trust, Stoll Keenan Ogden, and the Green Group. And I'd also like to thank today's panel sponsor, which is Rood and Riddle Equine Hospital. And our Q&A sponsor at the end of the panel is West Point Thoroughbreds. Our continued thanks to all the sponsors for their support of thoroughbred ownership and helping us offer these online panels at no cost to you. Now, we have a lot of ground to cover, so if you have a question, please use the Q&A button at the bottom of your Zoom screen where you can submit a question. And at the end of the panel, we'll answer as many questions as time allows. So now I'd like to introduce our speaker today, Dr. Larry Bramlage. Welcome, Dr. Bramlage.
Thanks, Gary. Good to be here.
I'll say a few words about you. Dr. Bramlage is a 1975 graduate of Kansas State University College of Veterinary Medicine, and he received a Master of Science degree from the Ohio State University in 1978. Dr. Bramlage is an equine orthopedic surgeon. He's a partner in Rood and Riddle Equine Hospital in Lexington, and he is the past president of the American Association of Equine Practitioners, also known as the AAEP, and the American College of Veterinary Surgeons. Dr. Bramlage recently was a recipient of the Denny Phipps Award that honors an individual who has demonstrated dedication to equine health. And Dr. Bramlage, you're a leader in our industry. You made a great and lasting impact in our industry. And it's a real honor to have you join us today. We really appreciate you taking the time to be here.
Well, thank you, Gary. It's good to be here, and welcome to everybody that happens to be on board.
Okay. So those in our audience, if you've been an owner for any period of time, you may have had a horse that had some talent, but found out from your trainer that the horse has a bone chip that may require surgery. So today we've got a video of a recent surgery that Dr. Bramlage performed last week on a 3-year-old colt to remove a chip from his ankle. And before we start watching the video, Dr. Bramlage, can you talk about how common these bone chip injuries are and how successful the surgery, like the one we're going to watch, allows the horse to return back to training?
Well, they're fairly common. It's sort of an occupational hazard. An ankle chip would be somewhere in the neighborhood of a human meniscus tear, a bucket handle tear in a person's knee. It would be sort of the similar amount of problem as you would need an arthroscopic surgery on your knee to get done. The whole key, which we'll talk about a lot of it during the video, is that you or I or the horse, we're mature and we have cartilage covering the ends of our bones, and that's all the cartilage we will ever have. Cartilage does not replace itself. Once you're mature, you can't form it anymore. So the whole key is to keep minor injuries like the chip fractures, or in the instance of a person, a meniscus tear, from doing damage to that cartilage joint surface, because that's got to last you your whole life. So we'll discuss the implications of the chip fracture. It's quite different than most people's concept of taking a rock out of your shoe. And the whole point behind removing the fragment is to stop the reaction of the joint to that fragment of bone. That reaction is actually what does the long-term damage to the joint. It's not so much the fact that you've got this little fragment of bone in your joint, or in the horse has it in his joint. It's the fact that he's trying to heal that thing, and then the reaction to the fragment and what is a healing process never gets the chip healed down and continues to do damage to the bone. So when we just get rid of it, the bone quiets down, it doesn't see any need to react, and then the joint goes back to normal. As far as how common is it, it's not half of the horses that would get a chip fracture. If you took all joints together, it might be as many as 1 in 5 that has some sort of problem similar to this sometime during their career. But fortunately, we're able to circumvent those now, and it doesn't ruin the horse.
I mean, is this something that could happen at any time for any horse in training, or do older horses that have been around a while, do they experience this on a less frequent basis?
Well, in the instance of an ankle chip, it pretty much can happen to any horse at any stage in his career. It's a repetitive stress injury. The impact of the joint in full extension gradually accumulates some wear and tear, and it's not like a chip fracture is not like you sit down with a piece of limestone and hit it with a sledgehammer. It's more like you have a piece of limestone and you keep hitting it with a ball peen hammer a little bit at a time, and eventually those little cracks coalesce and a piece may come off. Now, the majority of horses, though, that other 80% that never sustains this, they will repair those little cracks as they're accumulating. Now, chip fractures are more common in younger horses because they haven't made their skeleton, so to speak. All horses, as we've talked about so many different times before, horses aren't born with a racehorse skeleton, they make them. And the most common example of this is the buck shin. That's the process of the horse making shins that will withstand racing. Well, the same impact occurs inside of joints and to ligaments and tendons. And if you happen to have damage that accumulates, you might get one of these little fragments of bone we're going to talk about.
Okay. All right. Well, that sets things up perfectly for our first 2 video clips of the horse actually arriving at Rood and Riddle Hospital. And then the second clip that'll play right after that is Dr. Bramlage reviewing the radiographs and explaining where the chip is located. So let's go ahead and play those 2 videos, and then we'll come back with a question.
First thing that's going to happen is he's going to get his mouth washed out. So when we put the endotracheal tube down his trachea, it doesn't take any feed material to it. Now he's had that done. So he's coming into the recovery stall, which is where we'll induce him.
Okay.
Dr. Hubbell's going to talk here in a minute, but they get tranquilized first. This is the area of concern. I can blow that up. He has a fragment of bone in the front of his fetlock joint. You can see it here on this view as well. It came right off of that bone, and that needs to come out of there because of the reaction that it's creating underneath. We'll see that when we're looking in the joint. We'll see the debris that'll be being shed from this area. And most people have the concept that taking out a chip fracture is like taking a rock out of your shoe, and that's not it. The thing that causes the long-term problems in the joint is this reaction of the parent bone under it. And so he has one in the left. There are about 50% of horses that get one in one fetlock will get one in the other at the same time, but there's no evidence in the right. Comparing this side to that side, this is still normal. And this comes from just impact, where the horse's action causes the fetlock to go into, this is flexion, goes into extreme extension, and this bone actually hits here. And if it hits there, it can do this. And so if they do that, then we need to take it out. It'll take us about 30 days to turn the horse around, and he'll be back training again.
Okay, so Dr. Bramley, you mentioned in that clip that about half of the horses get a similar chip in the other ankle around the same time. Can you explain why that's the case?
Oh yeah, horses basically are symmetrical. If their anatomy is such that they're inclined to impact in full extension, the anatomy will be very similar in both front fetlocks. And so whenever we have a fetlock chip fracture or a knee chip or one of those types of injuries, we always check the other side, because if it's coming in the other side, the most common situation is you'll see one that displaces, and so it'll show itself to the trainer or the groom, veterinarian who's attending the horse. If we look at the other side, we very often see that they're in the same process on the other side. What we want to do is take them both out at the same time, because that takes us about a month to get them back to train. If we leave one of them in and he goes back to train and then separates it 2 months into training, then he's got to stop and get that one taken out again. So we try always to check the other side. And it's mostly because horses are made the same in both front fetlocks. Their anatomy is pretty close to the same.
Okay. So now that horse just walking into the clinic seemed to be walking fine. I mean, what was the clue at the racetrack that the horse had a problem? Was it heat in the ankle? Was it filling? Because he didn't seem to be walking lame to me. So what's the clue to the trainer that there's an issue?
Just as you say, it's the signs of inflammation, which are pain, heat, and swelling. He won't show overt lameness because that piece is not moving around significantly and shedding significant debris when he's just walking around in the clinic. But when he's got a rider on his back, the limbs are going to go into full extension, especially when the fetlock joint is fully loaded, and you'll see them. You know, we've all seen the pictures of how far down the ankle drops whenever a horse is fully loaded, either in a wind picture or in a video. And so when that starts to move that aggressively, then the horse begins to know it's there. The most common sign is that the horse is not training as effectively as he was. If the thing goes a little farther, then it'll shed enough debris that the fluid will start coming in the joint. But before the horse actually shows the fluid in the joint, they often know it's there, and they'll sort of hold back on their breezes, or they're just not training like the trainer expects them to train. And so that's when they go looking for something, looking for the signs of inflammation.
So it's just not an obvious sign of lameness. There's other factors they watch for.
Right. It's not like a condylar fracture or something like that, which is going to be lame immediately. This is more of a progressive disease that we're right at the start of it, and we want to interrupt it there.
Okay. So next we're going to view the horse going under anesthesia, where Dr. Hubble is going to oversee this process. So let's go to the next video clip of the horse going under the anesthetics.
We've assembled our team to induce the horse. See, we've placed a head rope. With a horse this size, it just gives us a little bit more control. We push him against the wall, and we have his foot about the rear end of the horse about 1.5 feet off the walls. And our ideal induction, which we'll hope to have here, obviously, is we'll giving the induction drugs as Lauren is doing now. She'll take control of the head, and the other folks will wait till the horse starts to feel the effects of the drug, and then they'll secure him against the wall and then guide him to the ground. Again, hopefully he'll just go backwards about 1 foot. And then once he's in sternal recumbency on the ground, we'll roll him out and go ahead and proceed with our anesthesia.
He's had a tranquilizer, a muscle relaxant, and then he gets an induction agent, which causes him to go unconscious. And then he'll get it.
Because we don't want him to get excited from hearing a bunch of noise.
Then he'll get a tube in and he'll be kept asleep using inhalant gas, which you'll see. You want to hold them against the wall so they feel secure when they're sliding down, because they're losing consciousness. You don't want them panicking. Main reason for that is they wake up similar to how they...
Taken a 1,200-pound animal and got him on the floor with minimal disturbance. And so first thing we check is his status at this point. We can see that he's still breathing, so that's good. You always worry about that with anesthesia. Lauren's going to go ahead and fill up pulse to make sure we have nice pulse quality as she's placing the endotracheal tube to secure the airway. So then we can go over and hook him to our anesthesia machine.
People always ask about holding horses upside down. Horses are built so that this doesn't bother them at all.
You can see that we use about a foot-thick foam rubber pad under the horse. And you'll also see that we'll pass pads between his rear legs just to support the weight of the horse. Again, horse weighs at least 1,200 pounds, and it'd be like you sleeping on your arm. And so you don't really want to sleep on your arm. You'd rather have a pad there. So we pad them as well as we can in order to protect them from muscle damage when they're in recumbency. So it's pretty important for us to get the anesthesia started pretty early after the induction of anesthesia in order to get enough of the inhalant on board to keep the horse asleep.
Okay, so that was pretty amazing to watch, Dr. Bramlage, just seeing that horse, go and lay down and having all those handlers there. Can you just talk about that process, Dr. Hubble's role, and having an anesthesiologist on board, just like in a human surgery?
Well, we didn't actually have Dr. Hubble for many, many years. He's retired from Ohio State, but the surgeon is ultimately responsible for whatever is happening to the horse whenever you're doing the surgery. It's so much of a plus to have him around because we have often 2 or 3 surgeries going at the same time with someone monitoring the surgery, the horse on the head while we're doing the surgery. And Dr. Hubble is a resource and monitors them. He trains all of our anesthesia techs. It just took a load off of us. And frankly, it makes it much easier for me to do the surgery when I have to only worry about what's going on the horse's leg than what's happening on his head.
Sure.
Good anesthesiologists are very qualified, but I think we hired Dr. Hubble after he retired from Ohio State, and we probably never will go back to not having an anesthesiologist available just because it makes everything else work so much smoother. It's
Sure.
better for the horse.
So is that process the same for a foal that was going to have surgery? I mean, they're a lot smaller, but is that process very similar?
The same, except we won't have to hoist them. We can just lift them onto the table. But virtually all anesthesia in horses has in common a tranquilizer, something to make them relax, and then an induction agent, and then they all go on gas. The reason you put them on gas is the induction agent disappears, and they can blow that gas off faster than they can metabolize the induction agent. And when it's time to put him in recovery, the faster we can get him from asleep and semi-conscious to fully awake, the better they stand up. So that's why gas inhalation is used in URI or in the horse. It's faster.
Okay. So now we're going to watch the full video of the surgery. And I've watched this video several times, and all I can say, it's pretty fascinating. So let's watch and listen to Dr. Bramlage perform the surgery on this horse.
Most notable thing here is my lameness as I'm moving around after having 3 knee replacements on my right knee.
I never noticed that.
Yeah. Stop. Just square him up. That way it will give us a little more room to record and all that. All right, that's good. Now, if this were you or I, they would have us bathing in chlorhexidine for 2 days before, but we obviously will wait till this goes up. Good. We obviously can't do that with the horse, but we use the same approach on the prep. We just have to isolate the surgery area from the rest of the horse. That's what the draping is for. That would be just the same as if this were you or I on the table. We have a little bit of an advantage in that the cleaner you are, the worse the bacteria on your skin. You have fewer of them, but they're much more aggressive. So horses have lots of bacteria, but the prep is pretty effective at sterilizing it effectively so that we don't have to worry about it. You can't get skin perfectly sterile because of the hair follicles. That applies to people or horses. But we just isolate the surgery site and then operate through this plastic film treated with iodine so that we reduce the amount of contamination as much as we can. She's going to put that right there. So we'll have 3 things hooked to the arthroscope: the light source, the camera, and then a fluid line so we can run fluid through the joint so it keeps the blood out of the way and washes out any debris. Arthroscopy became possible in the early 80s when the cold light source was invented, or the key to that was fiber optics. Fiber optics is now part of our lexicon. It's commonplace, but until you could transmit light without heat, you couldn't use a light source inside of a joint. But about 1980, it was actually invented in the US, but perfected by Japan. And then from that point on, almost all surgeries, whether it's on horses or people, whether it's laparoscopy for the abdomen or for joints is done by arthroscopy, which literally means joint looking. And so we use this arthroscope to allow us to see, and then we make a second incision to remove the debris. That's the fluid line I just hooked up. This is the camera, and then the cold light source, fiber optic light source is here. So that gives us the ability to look into the joint. And that's the chip fracture we saw on the radiographs right there. You can see all the blood supply around it. We'll take it out through another small incision. Most people believe you just put the arthroscope in and suck out the chip, but that's not the case. Here's the fragment right there. I just lifted it. You can see the reaction around it. So we'll remove that. It's about 10 times magnification forceps. And then the second and equally important part of the surgery is to remove all this debris. Give me a medium curette. These score lines that you see on the joint surface that I'm pointing to right there, that's the damage being done by this chip fracture. The chip fracture causes the reaction, and all these softened little pieces of bone, peapods, softened little pieces of bone get shed into the joint, and then when they get stuck between the joint surfaces, they create those score lines, and that's like sandpapering away your joint surface, and there's no way that'll heal. Cartilage has no blood supply, so you can't afford to have much of that happen. All this debris, this stuff that looks like sugar in a bowl on a humid day, that's bone debris, and that'll pass through the joint, medium curette. So we have to get rid of all of that. Stephanie, go up to 5, will you? So we'll remove this both with the curette and with the retrieval forceps. And removing this, besides getting rid of the debris so it doesn't try to pass through the joint, peapods, also lowers the profile of this eminence, so it's less likely to hit up here on the top of the joint, which is how he created this in the first place. So we'll take this anatomy down and reduce the size of the front of his first phalanx so that he's not going to hit as likely. Give me a medium curette. So you're doing the surgery totally by looking into the joint, and you have to learn to do that. I'm doing this, I'm right-handed, and I'm doing this surgery left-handed because you have to learn in order to do this. It is a little easier for me to do it right-handed, but by now I'm old enough that I can do it pretty much either way. The closest analogy is learning to brush your teeth. You weren't very good at brushing your teeth to begin with, but now it's second nature. Small elevator. And so you have to be able to work with both hands if you're going to be doing a lot of arthroscopy. So I'm cleaning all this debris, and the fluid going through the joint is washing it out as I create it. That's an important part also of the surgery. You want to get it out of the joint. P-pods. This soft bone is all a reaction to the chip. It'll just keep happening until we take that chip out of there. And it's part of the parent bone trying to heal the fragment back. It's trying to soften the interface between the fragment and the parent bone. And so it just keeps getting softer and softer, but that destroys the structure, which is what allows the debris to be shed into the joint. We want to stop all that. We'll go down to healthy bone here to where it's solid, small elevator. And then this is the cartilage margin where I'm debriding. I want that to be clean. I don't want any debris left. Anything that could shed into the joint, I want to take it loose and flesh it out. So that's good now. The profile is lowered. There's nothing that's going to shed. So this bone, this parent bone here, will stop reacting, and then it'll heal over with a fibrocartilage that looks sort of like this layer of synovial lining. It'll just get a scar over it. But until we take that piece out, that's not going to happen. So it's different than people's concept of taking a rock out of your shoe. This is more a biologic process, P-pods. So now that we've got this side done, we have to check the other side. That side's okay. He has hit, but that's what the top of the first phalanx should look like. But you can see there's lines on this joint surface there. And again, that's like sandpapering part of your joint surface away. And as long as that chip fracture is in there, that just keeps happening. Eventually you run out of cartilage. We have to walk on the cartilage that we were born with. So does the horse, or that we finish maturing with. I'm taking off some scar tissue that's forming on the bottom of this pad. That's a normal part of the anatomy, but once we take that piece out, that scar tissue will stop forming as well. And this is part of what stiffens the joint. We don't want to do that. We want it to stay nice and flexible. Now, none of this normally should look red like this. This is all inflammation. And it's happening because of that debris that's coming out of the chip fracture. And once we stop that, this covers with the scar, and that will cover with the scar, and the joint will go back to normal. That's the goal of doing this. And it doesn't take a long time. The scar takes about 40 days to form, so he'll get 2 weeks of stall rest. He needs that because he's got to seal up these 2 little holes that we created in his joint. And then he needs another 3 weeks to form the scar over here, over that raw surface of bone. But about 40 days, he'll be able to go back into training. So this is by far the best and the fastest way to deal with that chip fracture that he created. So now that we're done, we need to seal the incisions. So we use, long time ago, we would suture them. But now that they are better adhesives, we don't use sutures anymore. We use steri strips. which if you've gone to the emergency room with a cut, you might have seen some version. These are bigger ones. And they'll hold that together until it seals, and then you don't have to worry about taking sutures out or about the possibility that the sutures will get contaminated. So the first one of these I ever did took me an hour, but I've been practicing. It's pretty straightforward now. We do these almost every day that we do surgery. I need a scissors. Almost every day that we do surgery, so you should get better at it and faster. And so now Tori will put a bandage on it and we'll take him to the recovery stall.
The horse has done very well under anesthesia. Had good blood pressures. Feel very good about its reaction to the drugs we've had to give it to allow Dr. Brownlee to do surgery. We did an arterial blood gas, which we have here, which shows that the pH is pretty normal for a horse under anesthesia. The PCO2 is what it would be if you and I, if we took ours, it would be the same as we just saw in the horse. And its oxygenation is excellent, which is one of the things we're very concerned about with horses that we anesthetize, because horses don't do well in recumbency. They don't lay down all that much as part of their life, real life, I guess I'd say. And but lateral recumbency is better than dorsal in terms of oxygenation, but this horse is oxygenated as well as the horse can oxygenate during anesthesia. So Warren's sort of gearing down now, getting rid of the arterial line. We're about 5 minutes from leaving the room and going to the recovery stall. We'll go ahead and sedate the horse once we get it to the recovery stall to make sure that it gets rid of all the inhalants and has enough time to gather itself before it tries to get up. Because realize, still a 1,200-pound horse, he's still going to have to raise his body 2.5, 3 feet off the ground. And so that's more than anyone would ask of you or I as we're recovering from anesthesia. You know, they'll put us in a wheelchair and wheel us out of the hospital, typically if it's a day case. And in this instance, we have to have the horse standing. Usually they'll stand within an hour. Sometimes it takes a little longer than that. But we don't really want to rush them to get up. We just want them to get up when they're ready.
I'm going to give it a shot. That's what he took out.
Okay, so Dr. Bramlage, great video. So let's talk about what we're looking at here on the screen. Is this the chip and the fragments that came out of the ankle?
Yes, the one that looks kind of like an oval, that's the chip fracture, and it looked oval on the radiographs. The one there is right in front of Tori's right index finger. And then the small fragments around it, yes, that one. The small fragments around it are other fragments of bone that are the result of the parent bone trying to soften and reattach that chip fracture. And because it's a high motion area, that never happens. So the horse can't get it stabilized well enough. Now, if you put the horse in a stall and give it a long time, or let's say this happens in a horse's in the field for the winter, they'll get a scar tissue around the fragment of bone, and then it won't rub on the parent bone and you won't get that debris. But when the horse starts training again, the space between the chip fracture and the parent bone tends to wear out, and the process starts up again. And so that's why you don't have to take chips out of a horse's ankle if it's a filly and she's going to be a broodmare. We often leave them in because there's no stimulus for them to keep trying to heal, because the interface between the chip fracture in the parent bone has been neutralized by that scar tissue, but that scar tissue is very fragile. And so as soon as a horse starts training, he wears that out and the process starts again. So that's why it's way better to take this piece out and stop that process of the debris shedding. It, I said it's sort of like sandpapering your joint. Another analogy would be to throw a handful of sand in your car's engine every day before you start driving and expect it not to wear out. That's what the joint sees, is this debris starting to be shed into the joint, and then it moves around and it's grinding on the surfaces, makes those score lines we saw, and it just wears out the cartilage. And then
so was this a displaced chip, or was this chip still attached to the ankle? I mean, is that a fair question to ask?
Yeah, this is what would be described as displaced. It was separated from the parent bone.
Okay, and causing damage then. Okay.
Yes, but it's back to what we said to begin with. Chip fractures don't happen with one huge blow with like a sledgehammer. They happen whenever you have multiple small impacts, and then that small impact seldom makes a very clean fracture. It often has debris at the interface between the chip and the parent bone in the natural scenario. So we always take all of that out. In the front of a fetlock, you can be pretty aggressive and take out lots of that bone because it's not real important to weight bearing. That's not true in, for instance, a knee chip. You shouldn't be nearly as aggressive, and we'll be a lot more conservative and leave more of the softened bone to remodel and heal of its own. But you can't put those horses back into training at 35 days. You have to wait for that process to occur. Whereas in this instance, we just took out all the secondary response. So the parent bone sees it's gone, heals over, and goes back to normal. That's why it's so quick.
Okay, so that was a question I had coming up. So the difference in a ankle chip and a knee chip, there is a difference in that resurgery process and the recovery process.
Right. I mean, virtually every chip fracture is an entity of its own, and we're talking in generalizations now. But depends on where it's located and how big it is and how much of the parent bone is affected. All of that weighs into how much time it takes to take it out. But anytime you have the option, like we have most of the time in the fetlock joint, just to remove the whole process, that's much faster and much better for the horse.
Would you consider this a small chip, a large chip, or just fairly average?
Medium size.
Okay.
That's medium size. There are certainly smaller ones. There are certainly bigger ones.
Okay. Now you mentioned in the video that this is really the best and fastest way to deal with chip fractures. So prior to this technology, how was this done? Was it more invasive? Was it more of a surgical process where you had to cut into the ankle and suture it back up when you're done? So how was that process?
It's exactly so. I mean, in order to see in the joint, you had to make an incision. The incision in a fetlock joint would have been about an inch and a half or so, and then you use a retractor to open the incision, and you reach in and get the fragments out. That part was the same. Get the fragments out of the joint, but then you had to suture it back up. But then you have to wait for that incision to heal, and each joint has its nuances. In a fetlock joint, which has a lot of motion in front, that incision normally resulted in considerable thickening and lots of morbidity or lots of effect on the joint. Interestingly, the knee doesn't do that as much, but the bone takes longer to heal. So all chips are not created equal. There's a little bit of individuality to every chip and every anatomic location.
Okay. We've got a couple more videos to watch. I just want to remind the audience, if you have a question for Dr. Bramlage, go ahead and use the Q&A button at the bottom of your Zoom screen and submit it, and we'll get to those questions here in a little bit. So now we're going to watch the next video, which is the horse in the recovery process. So why don't we cue up that video of the horse in recovery.
So while they're moving the horse, you'll notice in the recovery stall, we have dirt on the floor with straw over top of it. That's a lot harder to maintain, but it's a lot better for the horse, because the important part of when a horse gets up is when they're still a little wobbly. When they first get to their feet, if they can dig their toes into the surface, they're much better off. If they slip, they'll sometimes fall. And that's the downside. We have rubber floored recovery stalls, but they're not as good as the straw at allowing the horse to get to its feet. It's the horse's natural surface. Plus, there's another benefit in that as they're waking up, as Dr. Hubble said, we want them to lay as long as they're comfortable laying there. And it's an environment that's natural to them. They smell the straw. It's someplace that's not foreign, as opposed to if you have a a rubber floored recovery stall, it's going to smell like disinfectant. So we put them in this stall on a mattress. Now they lay on the mattress until they can roll themselves up out of it. It's like having a bed at your home. If it sags in the middle, you got to roll yourself up out of the bed. Well, that's purposeful here because, as Dr. Hubble said, they weigh 1,200 pounds, so they sink into that mattress, and they can't immediately try to get up until they get conscious enough they know to roll themselves up. And then they get up on their feet, and we want them to stand the first time. In all of our recoveries, we have two people. There'll be a rope on the head and a rope on the tail, and we're not trying to pull the horse up before he's ready. But the reason for the ropes is when he gets up to his feet, and if he starts to stumble, we stabilize him with the ropes so he doesn't fall back down. That's one of our recovery guys. You'll see two of them here in a minute. They're also exercise riders, or were. They're an important part of the process. They lay with the horse until they feel like he's conscious enough to get up. Now, this horse is going to get up a little sooner than we normally would like them to get up. They start to stir. We'd prefer they just lay quietly. But Oscar's holding him down. He's resisting him, and now the horse is slowly gathering his wits about him. Now, not all people will do what Oscar does, and that's sit on their neck like this until they're ready. But you'll see when he does get to his feet, he thinks he's better off than he actually is, the horse. Now, if this were a colic or a fracture, we would sedate him a lot heavier so they lay a lot longer.
You're spot on, Doc. He's up.
He's up?
Yeah.
So he gets on his feet, and then now they're stabilizing with him with the ropes. It'll take him about 5 minutes to learn where his feet are. We don't want him to fall down during that time. That's the reason for the ropes on the head and tail. So they don't fall back down.
We've had the horse in recovery now for a little bit over a half an hour, maybe half an hour, 45 minutes, and he's just gone ahead and stood, which is within the usual parameters that we think about with a horse in recovery. He stood well on the first attempt. We supported him with the head and tail rope for a couple minutes, but now he's standing on the stalls, kind of getting his sea legs back, if you will, for those of you who are sailors in the audience, and just get him so he's ready to walk back from the stall. And again, think about you as a person. If this is you, you're laying in recovery, and At some point, they'll let you put your clothes back on and put you in a wheelchair and take you to your car, but you're not driving home. And this horse is going to walk back to its stall here in the 10 to 15 minutes from now. Everything went as well as it could have gone today.
So, I mean, my first observation is that guy, Oscar, did you say was his name, on that horse's neck? I mean, that looks a little dangerous.
It can be. And normally with people who aren't so comfortable with recovering horses, we don't let them do that. But we don't tell Oscar how to do his business anymore. He's been with us about 15 years.
Yeah.
So he actually sleeps on the horse's neck most of the time. He takes a nap during every recovery. And as soon as when the horse starts to move, he wakes him up, and then he gets in front of the horse with the rope. That's where we would have most people. But he likes laying those towels on the horse's neck and laying on the horse's neck and having the horse tell him when he's strong enough to throw him off. I mean, this is sort of the same degree of bravery, I guess, that the assistant starters have when they climb in the starting stalls with those horses getting ready to race. I mean, those guys, they're a different breed. And Oscar, he likes doing the same thing. We let him do it however he wants.
Well, I mean, one thing I gathered from the whole video is it takes a team to do this. You got a great team of technicians, you know, preparing the horse for surgery, being there while the surgery takes place, and then in the recovery stall. So just talk about the team and all the different roles involved.
Well, you know, when I first started doing surgery, when I was at Ohio State, and the same team would do virtually all of those steps. The main reason we have different groups working is to improve the flow of the horses through surgery, so we're able to do more horses. But it also specializes the individuals as they're doing their jobs. Each of the segments, we didn't see the first team that's involved, and that's my techs. When the horse gets there, they take the x-rays, they insert the catheter in the horse's neck. They be sure that the x-rays that we were sent in the mail match the x-rays that we take ourselves. That's actually my job, but they have them available. They get the horses all ready. And then the anesthesia group comes and gets the horse. When each of the surgeons, when we're operating during the day, will operate with 2 anesthesia teams. The one that has the horse in the room, there will also be another team that's getting the next horse ready. So it's sort of double teaming the dead time so that we can keep the flow going. Otherwise, we couldn't get all the horses that need surgery. We couldn't get them all done during the day, doing them one at a time. But you're absolutely right. There's a team of the pre-op. There's the ones that do the anesthesia. There's the techs that prep the horse and keep the ORs functioning with all the instruments. And then the surgery team, we're actually a small part of the puzzle.
Okay. So we got one last video to show, a little short video of the horse exiting recovery and heading back to a stall.
He's conscious, but he doesn't have all of his coordination back yet. That's why these guys will take him head and tail and get him back to his stall.
Okay, still a little wobbly, but looks like he's in great hands. So that process from the time the horse arrived at Rood and Riddle to that point where he's walking back to the stall, how long do you think that? What's that time frame? An hour, 2 hours?
It's roughly 2 hours.
Okay.
And then the biggest variable will be how long the surgery is. We will have some major procedures that'll take 3 hours in the operating room, but the amount of time it takes to prepare the horse, to induce the horse, is about the same. It's about 2 hours for those, and then extended. If we have a fetlock arthrodesis, that's half a day. We have a team tied up for half a day to get it done.
Okay. Now, prognosis on this horse?
He'll be normal. He'll be normal. That's the reason we take him out. That's the whole difference between arthroscopy and the arthrotomy that we talked about, how we used to have to do it. What arthroscopy did was change the treatment of this chip fracture to having surgery be the first line of defense. Get rid of the problem, don't have to deal with it again. Previously, we had a tendency to wait until there was no other option besides surgery. So that did a lot more damage to the joints before we actually treated them. There wasn't any, that's all we had back then. But now that we have arthroscopy, removal of the fragment and getting the joint back to normal is the first line of defense and by far the most effective. And that's why trainers have, over the years, they now lean on it as the first line of defense. They'd rather take a month and have the horse be back to normal than try to train him dealing with something for 2 or 3 months and then have it fail in the end anyway.
Okay, well, that segued into my last question. Can you wait too long to have this surgery and then the horse doesn't recover like this horse should?
Absolutely, because if you let that debris keep being shed into the joint and you continually destroy the joint cartilage, as we said, cartilage doesn't heal, doesn't have a blood supply, you don't have any more. You have to survive on what you had when you quit growing. You wait too long, you do too much damage, then the wear and tear gets bad enough that it continues to wear and tear on its own. If you can make the joint normal, then a normal joint doesn't wear. So if we can make the joint normal, much better off.
Okay, great. So that kind of concludes our talk, you and I, Dr. Bramley. So we're about to move into the question and answer period. And while we sort through some of the questions, please watch this video from our Q&A sponsor, West Point Thoroughbreds, and we'll be right back.
How do you become the gold standard in racing partnerships? One horse, one partner, one victory at a time. Congratulations to all our partners who have made West Point the gold standard for the last 3 decades.
Okay, Dr. Bramley, first question. How much more difficult is chip removal with good results at the back of the fetlock in the bottom of the sesamoid bones?
Well, every injury is individual. So that's called a base sesamoid fracture. And even those vary from simple and a quick turnaround to a problem that the horse never recovers from. And the reason being is the most common cause for a base sesamoid fracture is the bottom of the cannon bone wearing out. So to answer that question, you'd have to have radiographs to see how severe the injury was. You can't group those all together. If you have a fracture from the top part of the sesamoid, it's a lot more forgiving than it is from the bottom part of the sesamoid. And most recent example of that is Life is Good. That's what kept him out of the Derby. But we took the piece out of the top of his sesamoid and he was able to turn around fast enough. He came back and won the Breeders' Cup Mile. So if it's a simple problem, it's quick. if the base of the sesamoid fracture is caused by a problem in the cannon bone, it all depends on what the rest of the joint, the condition of the bottom of the cannon bone and the cartilage and all that. So base sesamoid fractures are often a big problem because they're not the primary problem.
Okay. Here's a question about what pain the horse might experience after recovery and going back to the stall or and being in the stall. How much discomfort does the horse have?
Virtually none. Interestingly, the first arthroscopy I ever had on my knee after I had a car wreck, they put me in a splint, and I was restricted in exercise for 2 weeks. This was an arthroscopy. Restricted for exercise for 2 weeks and then gradually put into rehab. Now they never do that. And you know why they don't do it? Is because the MDs, the physicians, observed how we handle horses and how fast they went back in order to start them into exercise. That led to principally a guy named Dick Stedman, who just recently passed away, who was at Vail, Colorado, to speeding up the aftercare of people. So it's horses that led to them getting you out of the wheelchair and walking down the hall the next day or even that afternoon. So that's a situation where the advancement in medicine came from the horse to the person instead of the other way around.
Okay. So what is the difference in a bone chip and an OCD?
OCD is a developmental condition. It's the O, C, and D are an acronym for osteochondritis dissecans. That means bone cartilage dissection. The cause is different. The end result is not. The reason you take them out is exactly the same. OCD shed debris into the joint, just like chip fractures shed debris into the joint. So the reason for removing them is exactly the same. The prognosis for most OCDs is good, but again, it depends upon the size, the location, which joint's involved, and what part of the joint's involved. So they have a lot in common. They lead to arthritis, and getting rid of them stops that process. But one is a developmental problem and one is accumulated wear and tear problem.
So it sounds like you would recommend OCDs be removed.
It depends on the situation, but if they have the potential to shed debris, you're always better to have them out.
Okay. Well, here's an interesting question. Does this type of injury happen as much with equestrian orient horses like hunter jumpers, dressage, etc.?
No, not as much, but it does occasionally happen. And the whole difference is there's a lot of difference. If you just intuitively thought what would be the hardest thing on a horse's knee and fetlock, you would think going over a jump would be a lot harder, but it's actually not. Horses are made so they can absorb that concussion. It's repetitive wear and tear. So if you're a cross-country 3-day eventer, you're more likely to get one of these than if you're a 3-foot hunter going over 3-foot jumps.
Okay.
It has to do with repetitive cyclic loading. So.
Okay. Here's a question about taking the horse's temperature during the surgery. Wasn't mentioned. Is that something that the anesthesia team does on a regular basis? Just keep track of the horse's temperature? No,
we don't need to do that. The thing as Dr. Hubble mentioned, the thing that we do to horses that they don't even do to most people is direct arterial blood pressure. And we have a catheter within the artery on the horse's face. That's the most important thing to monitor. Rarely, virtually never, I think I could say never now with the new anesthetic agents, gases that we use. The original gases would occasionally cause a problem that's called malignant hyperthermia. And so you monitored the temperature then, but that's 40 years ago. That doesn't apply anymore.
Okay. Here's a question. Do you use Genesen on joints?
Yes,
Okay.
but more commonly, we use them systemically, and that horse that you saw, he would have had it pre-op.
Okay. And I think you answered this question, but I'm going to ask it again. I have a filly ready to retire as a broodmare, recently diagnosed with an ankle chip. Should it be removed prior to being turned out, or can she get along without having it removed?
Generally don't need to.
Okay.
There are a few exceptions where they're in a location where they're prone to grinding on the joint, but in general, the answer is no. We don't take them out if they're not going back to athletic pursuits.
Okay. So once a chip is removed, is my horse more prone for a repeat?
Less likely to have it again.
Or even less likely? Okay.
Much less likely, because remember, I took the profile of that bone down. So now when he goes into extension, he's not as likely to hit the top of the first phalanx on the cannon bone. So they're very much, I mean, the probability of a repeat chip fracture in an ankle is in the single digits as far as a percentage. And it's only certain horses that are prone to that. Doing the surgery actually makes them less likely to get another chip if you do what you saw us do in that surgical procedure where we lowered the profile of the bone.
Right. Okay. So last question. Do horses that race on synthetic or grass surfaces have fewer injuries like this?
They're a little, ankle chip fractures are a little less frequent on synthetics and grass because their toes don't dig into the cushion. If a horse's toe digs down into the cushion, that people are under the wrong impression at why toe grabs were bad. Big toe grabs were bad because they caused the toe to dig down into the cushion of the racetrack, and then that drops the ankle, and that brings those two bones closer together. So they're a little less likely. Not a lot. They have ankle chips in England just as often or nearly as often as we have. But the disclaimer there is if your cushion is really deep, like if you have a 4 or 5 inch cushion, and some people have the misopinion of that deeper racetracks are always safer. That's not the case. If you have a really deep racetrack, you're more likely to get an ankle chip, not less likely, when you reach racing speeds. And so the footing of the position of the hoof wall makes the incidence a little less likely, but certainly grass horses get them. We didn't have a dearth of ankle chips whenever there were artificial surfaces all around in the tracks. Horses still got them. It's a sort of an occupational hazard of being a horse, like having a meniscus tear is an occupational hazard of being a human.
Okay. Let me see if we have anything else. So here's just a comment. Thanks so much. This was really awesome and interesting. Thanks, Dr. Bramlage, for taking the time to be here today. And I echo that. So that wraps up our Q&A.
You're welcome.
Yeah, Dr. Bramlage, yeah, big honor to have you here, sharing your knowledge, your insights with the audience. And I think I speak for everyone and just saying that this video of the surgery and your explanations, goes a long way in taking some of the mystery out of some of these common surgical procedures. So really appreciate your being here and taking the time and explaining this. And again, I find it to be fascinating. Well,
thank you. I mean, arthroscopy is actually, a sort of advanced surgical procedure. It's not just a shop vac with a view,
Right.
Doing something in there.
Well, to wrap up, I also like to thank our sponsors, especially today's panel sponsor, Rood and Riddle Equine Hospital. But most of all, I'd like to thank the owners who invest in our sport. Without you and your investment, we just simply don't have a product or an industry that we all love. So thank you for being with us today. We'll be back in November with another online webinar. And until then, we hope you visit the Winner's Circle often. Thanks, everybody. Thank you, Dr. Bramlage.
You're welcome. I'd like to thank the owners as well. They make my job possible.
Absolutely.